this episode of Behind the Paper, Macy Levin speaks with Dr. Gerald Brandacher about the field and his recent publication on chronic rejection in VCA.
I'm Dr. Macy Levin, and today I'm joined by someone who really doesn't need any introduction in the VCA world. Dr. Gerald Brandacher is one of the leading voices in reconstructive transplantation, and his new paper in the journal Transplantation really dives deep into the landscape of chronic rejection in VCA, why it happens, how it manifests, and more importantly, where do we go from here? So Gerald, thank you for being here with me today.
Well, thanks so much, Macy, for having me. It's truly a pleasure to be here.
So let's get started with the paper. Clinical manifestation, mechanisms, and potential targets of intervention for chronic rejection in vascularized composite allotransplantation. That's a mouthful, so we'll just call it VCA moving forward. But for listeners who really haven't read this or maybe don't know anything about VCA, do you want to give us a primer on what VCA is and why this paper is important?
Absolutely, happy to do so. So VCA is an up-and-coming field that we also refer to as reconstructive transplantation, and it is meant to restore devastating injuries and tissue defects that cannot be restored by any conventional means of surgery. And the goal of this is not necessarily to save a patient's life, but actually to restore both form and function and significantly improve the quality of life of those patients. The paper we wrote about chronic rejection, the idea came about that chronic rejection has become the major cause for graft loss in this novel field. And together with colleagues from the University of Louisville, we assembled a team. Christina Kaufmann has been working with me on this for a long time. And we felt, because it's such an important topic, that we want to put out a comprehensive review that really looks at all the different aspects of chronic rejection, especially because there's a lot of unknowns still. There's not really good animal models available to study this. And also, we have come to appreciate just the clinical importance of this topic.
Thank you. So one thing that, I saw in your paper is how you lay out around like what rejection looks like in VCA, right? So chronic rejection looks maybe different in VCA than it does in a solid organ transplant. Is that true?
That is true to some extent. Mm-hmm. I think reconstructive transplant, they are transplant, but they're still very different from the traditional solid organ type of transplants. And one of the major differences is that we are dealing with visible organs. And we can see immunology happen in front of our eyes. And we can see this with regards to acute rejection, but we can also see it with chronic rejection. And I think this really sets it apart when we talk about chronic rejection in reconstructive transplant versus solid organ transplant.
So things like skin changes or functional deterioration of whether it's a upper extremity, is that right?
That is right. Yes, there is some hallmark changes that occur on the vessels, and that's true for any type of organ, since we all have vascular supply to these organs and tissues. But then there are specific features in reconstructive transplantation, especially manifesting in the skin. This can be changes in the skin that are subtle. There can be changes in pigmentation, can be thinning of the skin, can be loss of adnexal structures, hair loss, and others, forms like sclerosis that can occur that are all signs of chronic rejection.
Okay, so those are the most important clinical signs that clinicians should be aware of if they spot this in patients?
Yes, if this is occurring in patients after reconstructive transplants, those should be really signs that alert you to look deeper and start other modalities to look into other signs of chronic rejection, but those are often the clinically leading signs because it's just the skin is a window into the graft, if you will. And that's a unique feature that really helps us actually to be maybe a step ahead sometimes in diagnosing acute and chronic rejection as compared to solid organ transplant.
That seems like it. You also note in the paper that environmental or physical trauma can accelerate or unmask chronic rejection. How clinically relevant is that to the day-to-day care of VCA recipients?
It is actually quite relevant. We strive to restore, as I said, both form and function. And the best thing we can achieve is actually if our patients use their transplants as normal. And they use it in daily interactions, not only social interactions, but they use their hands to work with. So they are constantly exposed to mechanical stressors. And those mechanical stressors, they can result, if they get to a certain level, in chronic inflammation that then can trigger further down the road alloimmune responses and perpetuate chronic rejection.
Wow. How many people have you seen with this?
I've seen a couple of patients that have had both acute rejection episodes triggered with mechanical stressors. Maybe just an anecdote, because we are now coming up to the holiday season. We had one patient that actually had a Christmas tree business back in Europe, in Austria. And every season around the holidays, when he was working on those trees, he had all those tiny little injuries to his transplants. And that triggered absolutely severe rejection episodes every single time around the same time of the year, until we figured out that this was a mechanical trigger. So it's real, it happens clinically. And then there is other patients that work as mechanics or work on farms that really have heavy use of their transplants. And that is something to be taken into consideration.
Wow. So kind of like a work-related use injury you might have. It's the same kind of context, but these are not inside, they're outside. So you have to be careful of what environmental stressors that you're putting on the organs themselves that are transplanted.
Yes, if they become excessive, then that can become a problem. There is also now more and more model systems where we're actually able to recapitulate that there is truly, it's kind of a trigger, that mechanical stimulation and this unspecific inflammatory response can then trigger an alloimmune response and acute rejection episodes in these type of transplants.
Wow, that's very interesting. So you also highlight some of these emerging mechanistic targets, complement pathways, checkpoint mediators. I'm saying all of these things and I don't necessarily understand them, but maybe you can enlighten me. And so of all of these things, like what stands out as the most promising for a future of an intervention for a problem like this?
That's a tough question. And probably, to be honest, I don't know the answer to it. I think the goal, treating chronic rejection is an elusive goal. We don't have any treatments available in solid organ transplant, and we don't have any available also for VCA. I think the best treatment of chronic rejection eventually is optimized immunosuppression, avoiding repeat injuries to the graft, such as repeated acute rejection episodes. And then, obviously, and that's maybe a little more of a distant goal, is if we could use co-stimulatory blockade or checkpoint inhibitors in combination with cell-based therapies towards an immune modulatory or even a tolerogenic approach, that per definition would mean the absence of an alloimmune response or a chronic ongoing alloimmune response. And that probably would be the best, maybe not treatment, but prevention of chronic rejection.
So that's kind of the goal ultimately, is to figure out how to prevent this from happening to begin with. So like, if you could tell me today, if you had to say any actionable recommendations to prevent or slow chronic rejection in these VCA recipients, what would that be?
I think the first one would be optimization of immunosuppression and ensuring compliance with immunosuppressive regimens. Probably limiting ischemic injury to these type of grafts and keeping preservation times short. And then the third one would be to really have very, very meticulous monitoring of the grafts, both clinically as well as when it comes to monitoring immunosuppression.
So when you say meticulous monitoring, what does that look like?
Again, as we have the skin that is visible, any changes that occurs, even if it's subtle rednesses, if it's changes that are occurring, if you notice beginning hair loss, don't wait. Reach out, contact the transplant team, and then start looking into this on a deeper level. I think falling behind is always challenging in transplant, and it's even more challenging in these type of transplants when we talk about reconstructive transplant.
So for patients that have reconstructive transplants, they have to just kind of always be paying attention and staying in contact with their teams to kind of monitor rejection. Are there blood tests too, or is it just kind of a watching the skin?
There is no blood test for chronic rejection, no specific biomarker that would tell us. It's being vigilant for those chronic skin changes that can occur over time or in the long run. And then it's as part of the annual workups, we look at ultra vessel structure using high resolution ultrasound and other imaging modalities to really do a very thorough assessment of any vascular changes that might be accompanying those skin changes.
Okay. So it's really being vigilant with follow-up protocols, adherence to medications, et cetera, sort of what we would tell any transplant patient to do, regardless if it's a VCA or another type of organ, right?
Exactly. I think that's a universal truth for any type of transplant.
Cool. So I want to move now to the future of VCA. You and I have worked together for a long time on, trying to talk about what type of education does the public need about VCA so this can become a more viable option for everyone who might need a transplant one day. And so I was just kind of wondering from you, like, when you look at this landscape, face, hands, abdominal wall, uterus transplantation, what do you see as the next frontier? And is there something that's coming that we may not be thinking of yet?
I think uterus transplantation is an example of really one type of VCA that is really gaining more and more traction, and there's a huge need for these type of transplants. There's other type of reconstructive transplants, such as urogenital transplants, penile transplants with devastating war injuries. Mm-hmm. But then I think more looking into the future, as we find novel ways to reduce immunosuppression, to enhance nerve regeneration, we are turning more and more towards the transplantation, not of entire arms or an entire face, but of smaller functional subunits, for which there is also no conventional reconstructive option available. And that would be, for example, transplanting eyelids, which have devastating consequences, resulting in blindness as you're constantly scratching your cornea, for example. But an eyelid cannot be really constructed well today with reconstructive surgery means. The same is true for parts of the nose or the entire nose, lips, ears. Those functional facial subunits, they cannot be reconstructed, but they could be transplanted. And as we move forward and can minimize the long-term burden or hopefully avoid it at some point of immunosuppression, that would open up an entire new field of reconstructive modalities for patients with that type of injuries.
Wow. And there's a lot of people that need those types of procedures, you would say, around the world?
Yes. Yeah. Yes, there's a large patient population with these type of injuries.
Wow. So what do you see then as the biggest bottlenecks right now? Is it the immune system, right? Not necessarily being able to have the best immunosuppression for everybody yet, and that's a universal truth in transplant. Um, selection of donors and recipients and candidates for surgery, functional outcomes, or like, is it the capacity of our transplant system or systems around the world to make these types of transplants possible?
I think it's a little bit of all of them, all of the above. But I think the major limitations to really move forward with transplant endeavors such as the transplantation of functional subunits is still the need for long-term immunosuppression, because these type of transplants are still considered non-life-saving. So the risk-benefit equation needs to be addressed very carefully. If we would be able to avoid immunosuppression, then I think that could open up indications quite significantly. Enhanced nerve regeneration and thereby improving outcomes. Nerve regeneration is a very slow process, and so far there's really no treatment to really speed that up significantly. Although there's now modalities on the horizon and in experimental work that hopefully will help us also tackle that problem and enhance nerve regeneration and thereby improve functional outcomes. So that again could lead to expanded indications. But then I think the greatest bottleneck or the greatest hurdle at this point is a lack of funding for these type of procedures. They are not covered by insurance at this point, and this really is a limiting factor that we don't see more clinical cases, and kind of the field has slowed down significantly because of a lack of funding for these procedures.
So if somebody needs a reconstructive transplant, how does it get paid for?
In many instances, it's paid through institutional support that transplant centers who have reconstructive transplant programs, they support these type of transplants. Philanthropy is still a major mean to support these type of transplants. And then there is occasional agreements with insurance that are made on a single case basis. But I think for the field to really expand, we need to have coverage of these type of procedures, the same as other type of solid organ transplants are currently covered.
That makes sense. So if you imagine the field, let's say 10 years from now in 2035, what does VCA success look like to you, right? Is it more programs, better outcomes, more indications? How do we get where you want us to go, or where can we go in the next 10 years?
For me, really honestly, the biggest success that I could imagine for this field is if it were to become, if you will, a standard procedure. If this just becomes one modality in the broad portfolio of different treatment options that we have for patients with devastating tissue injuries or amputations, that could help them to restore them back to normalcy and both restore form and function. If this can be something that we can offer the patient safely and successfully on a routine basis, I think that would be the greatest success that the field can see in the next 10 years.
So moving this to routine care, not exceptional care or under a research protocol or something like that, that is paid for, that is known to be something that a patient can ask their clinician for and receive, and have a way to make that actually happen.
Absolutely. I think it should be one option, an additional option that we can offer, because transplant might not be right for everyone, but it is the best option for many. And I think the patients should have the ability to choose out of this many different options, whatever they feel is best for them. But I think transplant should be one viable and realistic option for them to consider as well.
Got it. So what about from the donor side, right? We think a lot about donor families saying yes to a gift, authorizing VCA, which we don't have to go into that, but it's a separate process than it is for solid organ, right? So if a family is approached about having their loved one be an organ donor, the conversation around would you be willing to authorize donation of heart, lungs, kidney, liver is very different than, let's say, we would like to see if you'd be willing to allow us to recover tissue for a hand or a face, for example, right? That's very, it's a separate authorization process. Is there something from your experience with this uniquely important to prepare donor families for the ask or for the process itself of donation for VCA?
I think what I've seen is that it is important to have the ability to share with the donor family some of the history of the potential recipient, because those are very individualized type of procedures. And usually there is a very compelling story behind the recipient on how that injury occurred. And being able to share this with the donor family, why there is a need and how we came to a point to even ask for this unique gift. I think this really helps the donor family to understand the need. And I have to say, I'm amazed every single time we have these conversations about how gracious the donor families are and how understanding that in this really very difficult moment in their life to help another person with this very special gift.
So always focusing on what the gift can do and what type of life-changing results it could be for the recipient is important for us to continue to talk about with donor families and probably the general public, right? As we can try to educate people about VCA as a treatment option for challenges that people face in their life, regardless of how it happened. It could be a really important conversation that people understand it's possible, right?
Absolutely, yes. And the other, I think, really important aspect is to ensure that these type of donations can be done without any disfigurement to the donor body. I think it's very important to explain to the donor family that we will restore, obviously, every defect that has to occur because of this gift. And I think that's important also for the donor family to realize that we are not taking an extremity or parts of the face and leaving a defect, that this can be reconstructed and restored using various different modalities in a way that there is no disfigurement to the donor.
And so that honors not only the donor, but honors the family through their grieving process and whatever final arrangements that they might have, to know that it won't impact that as well is probably important. That's probably a misconception. People probably don't really understand that.
Yeah, I think that is very important that we can assure the donor family that this will be done and has to be done.
Fantastic. Okay, so I want to shift gears a little bit from VCA because I know you are, very knowledgeable about the future and are always thinking about what's next. And I want to learn more from you about cryopreservation and anything about preservation science. So, I'm hearing that organ preservation is kind of just exploding. I have people ask me all the time, well, I hear y'all are doing pig transplants, but when are you going to be able to build one off of, my own body? Or when are you going to do 3D printed? Or when are you going to be able to keep an organ from a human longer so that I may not need something else? And so I struggle answering those questions, and I'm always like, well, I can ask an expert. So here I am asking an expert, right? What's the most exciting thing in this new world of cryopreservation or any preservation science that's really exciting for you right now that you're paying attention to?
Yeah, I think you're spot on. I think we we have the privilege that we are kind of practicing transplant medicine at a time where there is so much advancement in enabling technologies that really allow us to think about strategies that we couldn't imagine just a couple of years ago, and now we're actually going there. I think the excitement that comes with organ preservation is that we are now at a point where I think we can take time out of the equation in transplant. And that is, to me, is a paradigm shift. If you think about any aspect in transplant, whether that's starting with allocation, that's the matching process, that's innovative treatment concepts, that's desensitization, whatnot, any aspect of transplant is always limiting by time. We have never enough time to work on any of those areas. If we can take time out as a consideration in transplant and talk about storing organs for days or even beyond, then I think that the possibilities are just endless. This will change transplantation as we know it.
I mean, realistically, if we can take time out of the equation for your average human organ from a deceased donor, what does that mean for all other sources of organs that we're hearing about today?
I think these technologies such as sub-zero organ preservation or innovative machine perfusion technologies, it has been shown that they are universally applicable. They not only work in one specific type of organ, but they work across the board. And I think this just will change all the innovative aspects. If you think about, for example, the latest advances in xenotransplant, those genetically engineered organs, they need to be transported. There is not going to be enough time. There is a lot of logistical challenges. And if you have a method available that allows you to safely transport those organs across the globe over 48, 72 hours or beyond, that would just open up this technology very differently than what we do currently. And that's obviously true also for sensitization, where you have desensitization protocols now available. Most of them, unfortunately, do not work in a deceased donor setting, but only in a living donor setting. That can be planned. So now, if we can take time out of the equation again, transplant becomes an elective procedure across the board. In health economics, we are not going to transplant at night anymore. We are not going to transplant on weekends. This might actually take off a significant financial burden from the healthcare system if we don't need to pay nighttime OR hours, which are one of the most costly items in healthcare at all, if we can make this an elective procedure. So there's so many aspects. We can implement sophisticated matching modalities. If you think about how we actually perform transplants today, is pretty astounding how basic the matching process still is after all those years. We have tools now on a genetic level that really would allow us to do a way better assessment and matching between donor and recipient, which we know translates into better long-term outcomes. And those can be implemented again, but they require time. And all of those aspects, I think, can be changed with these new preservation modalities. And this is why I'm so excited about them.
Wow. I mean, I kind of understood, but now I really get it, right? I mean, if you can extend viable preservation to, what you're talking about, it really changes the whole transplant system, not only in the United States, but everywhere in the world. We won't have considerations around geographic access challenges, logistics around, how things are going. I didn't understand. That's a new thing for me. I didn't know that it costs more money to have an OR in the middle of the night. I mean, I could understand why, but I never thought of it like that. So you're talking like really basic things that this type of sub-zero preservation technology could really impact our international systems, not just that in the United States, right? Like it can work everywhere.
Oh, absolutely. Yeah. We could really start even thinking about global organ exchange, although there's a lot of other issues that need to be worked on rather than just being able to gain more time. But I think we are getting a significant step closer to actually starting these conversations.
Wow. So I know your group at Johns Hopkins and now in Austria really have done foundational work in this sub-zero preservation space. Can you talk to us a little bit about your shop and kind of where things are now in terms of translating these grand, awesome things into clinical realities?
Yes, so we are in preclinical studies in kidney transplants. We are also in large animal studies in the VCA realm with this sub-zero preservation technology. Together with our partners from Extherma, we have gotten FDA breakthrough device designation on this technology, and we are now in the last steps to work with the FDA to initiate a first clinical trial, and the goal is to initiate that trial in 2026. So we are getting there.
Congratulations. That's a lot of hard work to get there. I truly do understand. And I mean, so how long would that trial be, right? So let's say you get started in 2026. Are we looking at, 2030 before we might see something like this regularly utilized in the clinic?
The beauty about this technology is that it is actually very easy to implement because we are merely replacing one preservation solution with another. It's seamless in the process, can be integrated into the process of a multi-organ recovery. There is no additional equipment or training needed. This can be done at every remote donor hospital. And that I think will help with adoption. Every transplant surgeon knows how to flush an organ. And this is simply another solution to flush an organ with. And then we can store it at sub-zero temperature with a new storage device that, again, does not require oxygen, does not require electricity. It is all based on chemistry that actually can keep the temperature stable over a certain period of time. And that will help with implementation, I think, quite significantly.
Wow. So do you think that better preservation could actually help reduce chronic rejection in any cases, or are they kind of separate issues?
No, I think it should be able to help not only with chronic rejection, but with overall outcomes. I think if we can reduce ischemic reperfusion injury with better preservation, and maybe even with a combination of sub-zero preservation and machine perfusion, so that if we do a controlled rewarming on these machine perfusion devices and have the initial ischemic reperfusion phase happen outside the body, and then transplant an organ that has had this initial inflammatory burst, that could help with reduced rates of ischemic reperfusion injury, hopefully translate into fewer rejection episodes, and thereby also in better long-term outcomes with less chronic rejection.
So it kind of all goes together. If we can do better preservation, we might be able to ultimately make the organs work better for people longer all around the world, and better for those actually doing the surgeries as well, right? Because logistics won't be as big of a challenge.
Yeah, I think that would be the vision. And I think we know in transplant, there is not a single component that actually, it's all of these components, they are interconnected. And if we can significantly improve one of them, I think we see a downstream effect on many other areas.
Amazing. Is there anything else you want to share about the future of VCA or preservation with any of our young listeners, particularly those around the world who are looking at transplantation as their entry point into healthcare, and they want to know where they should spend their time? What advice would you give them, or anything you want to share with them would be awesome.
Yeah, I think if you want to get engaged in this is your chance. This is the same feeling as it must have been when Dr. Murray did the first kidney transplant or Dr. Starzl did the first liver. There is so much uncharted territory, so much new areas to explore and to understand, that you can go into this new field in transplant, find your niche, and just contribute to moving the entire field of transplant forward. And I think that's an opportunity that every young person that looks at transplant today should be excited about. And I think this is probably the most exciting time we've ever seen in transplant. And it's a bright future ahead for the field.
I love it. Awesome. Gerald, this has been fantastic. I really appreciate you sharing both the science and your take on the future, what's next in VCA and preservation with me. I really do appreciate your time, and love all the work you're doing, and can't wait to do a follow-up and learn about how these preclinical trials are going soon.
Thank you so much, Macy. This has been fun, and I would love to do a follow-up at some point. Thanks so much. Appreciate it.
Yeah, amazing. So for our listeners, the paper we discussed will be available in the show notes, and it's currently published in the November 2025 issue of Transplantation. Thanks so much for joining us, and we'll see you next time.
Thanks for joining us. And be sure to subscribe to our channel so you never miss an episode.